So, first and foremost, I would like to thank a couple people before I get started. Um, the first group that I want to thank is NISPA as a whole, New York State Psychological Association. You're fantastic. I know that in central office, you do a lot to make sure that really powerful programming like today's program um, can occur. We also have a division within New York State Psychological Association, the Adult Development and Aging Division, that they deserve an acknowledgement, as well as the Association for Hispanic Mental Health Professionals. Um, they sponsored the event, but last but not least, Roy Aranda, Rafael Javier, and St. John's University. Thank you for housing the program, organizing the program. It has been a delight to be part of this full day event. Um, I do apologize that I could not make it there today, but I wanted to give pre-recorded message and make sure that my content is represented. I'm very fortunate to be presenting with two great scholars in Sharon and Patricia. I look forward to seeing the transcripts of your remarks as well. So, just a little bit about the talk. The talk comes from a couple different areas, but the first area actually comes from my mother. When my mother was struggling with lung cancer, she was given about 10 months to live, and I became her primary caregiver. And she passed away in May 2007. But I wanted to do something special for her, and the first paper I ever wrote was related to caregiving for the terminally ill. So I want to dedicate this talk, similar to that paper, to my mother, Chaya Amy Bas Avraham. And with that, I begin. So before we start, really there are questions. Well, who or what is a Jew? There are different discussions about this. First and foremost, if you go back within the Jewish text, the Bible in Leviticus talks about being born as a Jew to a Jewish mother, or a person has the opportunity to convert to Judaism, right? So the first identity factor is a birthright. And then there are people who don't adhere to Jewish practice, but they identify strongly with their cultural identity. There's also an ethnic identity, and the ethnic identity developed as a function of diaspora, and I'll explain that. Then there's a nationality, so there are different levels of connection to the land of Israel. And then there's different levels of religious adherence or religious practice. Now, when we talk about Jewish identity, one of the things that I highlight is that it's multidimensional, and each dimension is interrelated with one another, so there is some level of intersectionality there. Talking about the various exiles, you might hear the term Sephardic, Ashkenazic, or Mizrahi. Someone who is Sephardi comes from Spanish communities. Sepharad actually means Spanish, but it's not just Spain, it's many of the further diasporas from Spain as well. We also have Ashkenazi. Ashkenaz are European Jewry, and then Mizrahi. Mizrach means to the east, so we have Far Eastern and Middle Eastern Jews as well. And if you're really interested, there are some people who talk about Jewish ethnic identity, and they debate whether Mizrahi and Sephardi could be absorbed into one. But the most important aspect of Jewish identity for an end-of-life care talk is levels of religious practice. So I'm going to introduce you to a couple terms. So Orthodox, Conservative, Reform, and Unaffiliated, And the focus of this talk is specifically Orthodox Jewry. But Orthodox Jews accept the Bible as divine and give the rabbis the authority to interpret the text. You have conservative Jews, which are more traditional than Reform Jews, and they come as a reaction to Reform Judaism. And then you have Reform Jewry, which they kind of chucked many of the core tenets of Judaism. They don't believe the Bible is divine, and they wanted to have upward mobility within European society, so they reject many of the traditional values. And then there's the term unaffiliated or just Jewish. These are people who are ethnically or culturally Jewish, but they don't observe many of the customs. So, but the focus of this talk, as I mentioned, is orthodoxy. So just to set the stage, there are a lot of Hebrew terms. I'm going to try and note them and then define them, and then we'll talk about their application. The first term that's of importance is something called pikuach nefesh, which is the concept of preserving or saving a life. And this is at the cornerstone of Judaism. In fact, it's so essential that all other aspects of Judaism can be violated to save a life. For example, a person, if they needed food, you could feed them non-kosher food to save their life, or you could even violate the Sabbath to go to them or to make sure they're okay. And then, so pikuach nefesh, it's a cornerstone, as I mentioned. Trying to maintain or sustain or save a life is essential. So different kinds of terminal illnesses within Jewish law. There's something called a chaye sha'a, which is a short-term survival, and there are different subdivisions. There's a treifa and a goses. A treifa is a person who has an incurable illness which has a limited life expectancy. Within the Torah, this is defined as 1 year or less. Now, it's interesting. We know that within the non-religious community, the cutoff is 6 months, so that might have some applications there as well. Then we have a goses, which is a person who's going through the death throes, which usually is the last few days of their life. So these, when we talk about terminal illness and a lot of the decisions that you have to make, we have to determine whether the person's a chaye shah versus a chaye olam, which is a person who has a more long-term prognosis. Obviously, the theme of today's talk would be focused on a chaye shah. So let's look into Jewish law. A lot of the sources that I'm using today comes from Kinsbrunner, and this author did a fantastic job reviewing the different issues within Jewish law. So the first thing that Kinsbrunner talks about is suicide or assisted suicide or euthanasia. This is one where Orthodox Judaism takes a hardline stance and says it's forbidden. You cannot facilitate ending a person's life actively. In fact, that would be tantamount to murder within Jewish law. What about refusal of medical care? Well, believe it or not, just because you can't facilitate suicide, a person has the right to refuse medical treatment, even within Orthodoxy, particularly when they've deemed that the medical treatment is going to be ineffective, futile, or cause further complications. So a refusal of treatment is okay. So, and then when we talk about withholding or withdrawing from treatment, I'm sorry that one of the bullet points for withdrawing should be indented. So withholding treatment is permissible. Withdrawing treatment is not permissible. So it's forbidden to withdraw life support or anything that is preserving life. So one of the discussions that you'll see in the rabbinical responsa is whether or not to put someone on life-sustaining medication, because once you're put on, it's very complicated to take a person off. Now, the ancillary aspects to make a person comfortable or impediments to death, that's not held to the same degree as turning off a respirator. So removing the impediments to death are okay and acceptable. So in terms of treating pain and suffering, it's an obligation to treat both physical and emotional pain. So you want to treat the whole person, the mind-body aspect of this individual. And then obviously, in the face of immense pain and suffering, you can withhold any impediments to death. So if you see that the person is in agony, you can withhold things that would facilitate pain and suffering. CPR, so a person can have a DNR, do not resuscitate. So CPR can be withheld as well. What about artificial nutrition, nutritional support or hydration? Generally, we talk about food and liquid here. If you're going to withhold that, it should be done in a way that benefits the patient and avoids harm. Antibiotics should be provided if it's considered a separate illness, but it may be refused or withheld if they're delaying dying process. So we're going back to this theme. You can't facilitate the dying, but you're allowed to, you don't have to impede the dying process within Jewish law. Other things like surgery, chemotherapy, radiation, it can be refused or withheld only if it's going to not result in relief of pain. So if a person has a stage 4 metastatic cancer, let's say, it might be okay in that context to not undergo chemotherapy or radiation. And they can choose that, and within Orthodox Judaism, that's honored. A ventilator, it can be withheld, but once it's initiated, you cannot actively discontinue it. You can't shut it off because, as I mentioned, that would be considered an assisted suicide to some degree. And then the discussion of advanced directives, I hope that other people are going to talk about advanced directives, but it's very important to have advanced directives to know the wishes of the patient, because the wishes of the patient matters more than our personal interests as caregivers. So that should be drafted while the person is healthy, and if not, while they're lucid. Now, within Orthodoxy, if a person wants to consult a rabbi, it would be recommended or advisable to bring the rabbi in to consult in advance directives if that patient feels that that could be helpful to them. All right, so what about from the patient side? So now you have all of the Judaism's view on major decision making. Well, unfortunately, what we find is that once a person is deemed to be terminally ill, they receive less medical care. If you work in rehabilitation centers or geriatric facilities or whatnot, you will see that once a person is deemed to be terminally ill, then they're given less medical attention. We also know that this person can be activated with strong emotions, anger, depression, all kinds of cognitive impairments, etc. So how do we process these experiences? One of the first theories that we hear on stages of death is Kubler-Ross. It's a good theory. I like it, but it's incomplete, as most people, if you look at the more modern research, will say. All of the stages are appropriate. So denial would be, no, this isn't happening to me. It can't be. I want a second opinion. These kind of statements would be indicative of denial. Anger and resentment. So this is where a person now they recognize that they are terminally ill, but they're um, bitter about it, um, and that they're resentful that why me is the kind of question they might ask. Then they might bargain for more time. Oh God, if you give me more time, I will do dot dot dot. And then when they discover that the bargaining is ineffective, many times they develop depression, and then ultimately they reconcile this and come to a level of peace and acceptance with it. But the way Kubler-Ross presents it, it's sequential, and more modern researchers say that they don't go, not everyone goes through every stage. Moreover, people can repeatedly go back and forward through the stages, which is inconsistent with the original formulation of Kubler-Ross. So here's to get to some of the dialogue you as a clinician might have. I picked a couple really interesting ones from Bornman and colleagues. They talk about palliative care and pastoral counseling and whatnot. And I thought they did a good job in talking about how to listen to your patients, probe further, and intervene. So here's a couple of them. I feel abandoned by God. This is not uncommon. Many Holocaust survivors will be further activated by this statement. But as a clinician, you might sit back and probe a little bit further and get clarity. So you might ask, well, in what ways do you feel abandoned by God, right? And then you might explore, well, is it God, or are they feeling more general disconnection from the Jewish community? And an intervention, if that's true, is explore ways that they can reconnect with the community. Because keep in mind, a person who's Orthodox, there is a concept called religious coping. Kenneth Pergamen, David Hilla Rosemarin, and many of these people do a lot of the studying of religious coping within the Jewish community, and they found it to be beneficial. Other things, a person might feel that they're being punished. You'll hear in Hebrew the term, this is a kapara, so it's somehow an atonement or a punishment. And for me, if I ever hear this, I just sit with the patient. I don't say, oh, does that seem fair? Does this, that, or another? I just sit with them and ask them, well, can you share with me what makes you feel this way? And then usually I find that the cornerstone is guilt. So we might explore what the feelings of guilt are, and if they can process these feelings of guilt, that also helps them come to that acceptance that Kubler-Ross was talking about. So in terms of treating Orthodox clients, you'll see a lot of ambivalence. So if you don't know an Orthodox client, this ambivalence might be perceived as resistance, but built into Orthodoxy is this dialogue or Socratic logic. So they might have this internal debate within themselves, and that might not be resistance, but might be part of how they process their experience. Also, I don't recommend using prayer and scriptures for everybody, but if you have an Orthodox patient and you know scriptures or verses or pasukim, however you want to say it, it could be useful to take an insight from one of the verses and use that as fodder for the session, and you can process that with them. And then obviously, the more removed the person is from orthodoxy or their faith, the less recommended using prayer and scriptures would be, because it may not help them cope. This is essential for me. I've seen that, again, there is this whole process of atonement and seeking forgiveness and whatnot, and at the end of life, the rabbis are involved with that with the patient. but I would say use rabbis as a cultural broker as soon as possible, because for many Orthodox patients, the first person that they're going to consult is their rabbi. And there is more training for rabbis to encourage Orthodox clients to go see a psychologist or a practitioner, um, but that might be helpful. And then, if possible, see if your client will give you consent, and then you might use the rabbi as a collaborator as part of the ongoing process. Um, just be mindful that if you're not part of the Orthodox community, there are a lot of potential landmines you can step in. So bringing the rabbi in will help them reconcile some of the aspects between their treatment and religious practice, because ultimately sometimes people need to be told it's okay to violate law X to save your life. And the rabbi would have the authority in an Orthodox client's mind to do that, whereas we as psychologists may not. In terms of treatment, I want to impress, most people will say, well, should we use CBT or psychodynamic psychotherapy? And I'm going to make a case for both of them. I think that, sorry about that, I had a pop-up. I think that both intervention modalities are great. And the case for psychodynamic treatment is that many Jewish clients will respond very well to introspection and tapping into the unconscious and how that shapes their religious experience. You might see countertransference in working with a person when discussing religious issues that they'll superimpose on you. The other aspect or other modality would be CBT, and because Orthodoxy is highly ritualistic, you might want to consider using CBT to address some of the anxiety symptoms as well, or ritualistic behaviors.